Hello everyone, I'm Dr. Darsha.
And I'm Dr. Altamash Raja.
And welcome to Medicine Redefined,
a podcast where we will explore the often overlooked but necessary components of health, what we consider to be the fundamentals.
We will investigate topics and practices that can give you and your patients the best chance to optimize a healthy lifestyle. It's time to move the needle forward and put the health back in healthcare. Hello everyone, our episode today is a wonderful delight and a true treat. Our guest is the one and only Dr. William Cromwell. He is a clinical lipidologist from Raleigh, North Carolina, and he has been a tremendous voice and an academic leader in the fields of cardiovascular disease and lipidology and metabolic health. He's also the chief medical officer of Precision Health Reports. Now, if you are a recurrent listener, that company may ring a bell because the chief executive officer, Matt Martin, was previously on this show. And so today we have his partner in crime, Dr. Cromwell. Now, if you aren't driving, I highly suggest you get a notepad and a pen or pencil because you're probably going to want to take a lot of notes on this. Lipidology has been actually one of the most popular themes of our podcast. Dr. Nicole Harkin, who was previously on our podcast, is one of our top ranking episodes. And so we decided to deep dive lipidology again. But this time, we're going to look at it through the lens of precision medicine and metabolic health. And so while we're going to be talking about markers like Lp(a) and ApoB and bust the myths on LDL and HDL, we're going to get a little nerdy. So having a notepad might be useful. You might gain things that you're going to want to bring up to your doctor or that you might want to Google and go down the rabbit hole a little bit later. So this episode is full of information. It's super practical. It's things that you will look into, I promise, because this is the future of medicine. All right, let's get to it. All right, Dr. Bill Cromwell, thank you so much for coming onto the show and sharing your expertise.
Well, thanks for having me.
Absolutely. So not too long ago, we had your counterpart, Matt Martin, come onto the show to talk about Precision Health Reports. And, we kind of covered the basis on that. But now we have you to really deep dive into the science of lipidology. And so we can nerd out on that. One of the things we love to really ask our guests is their journeys. What might have been those key events that got you into cardiology and then more specifically lipidology that kind of kept you on the straight path or maybe even led you astray for the better?
No, that's a great question. Actually, it's a funny story because I started as a physical chemist who went to medical school. I was a young guy, I got to medical school, and so I just asked a couple of questions. What kills people? Vascular disease. Well, how do you stop that? We're not entirely sure. What options do you have? And as they were ticking off things from hypertension to diabetes, we got to this thing about lipoproteins and cholesterol. I said, now, wait a minute, you measure that, right? Well, yeah. Well, I'll do that. And they said, nobody does that. But that's kind of a crazy thing. But at the same time, I thought to myself, if the number one killer of Americans is still obtuse, and there's something about analytics that could play a role in this, that seems like a good place to start. So very intentionally in medical school, I was very interested in lipidology. And through my residency and fellowship, I just charted a beeline straight to lipoprotein disorders. I started my first lipid clinic in the late 80s, at which point very few people cared. If you can think back that far, we really didn't have statins to speak of. They had just launched Mevacor. We didn't have very many outcome studies. We didn't really know if doing things in this field was going to help people. And sometimes you get lucky. And so that's basically what happened. I had a passion about something. I invested my time in there, and lo and behold, it became to be something of importance. And so that's been, the short story of 30 plus years.
I love that. It's a very logical progression. It's like, yep, that's what I'll do. We'll measure it. And yeah, I can only imagine because it's, especially the United States, right? We've dragged our feet when it comes to measuring Lp(a) in people in the younger population, at least earlier in their lifetime, especially ApoB with the guidelines. And so I can only imagine what it was like 30, 40 years ago. Now, you're not the first lipidologist that's been on here, right? We were talking about that offline. Dr. Nicole Harkin, shout out to her. But long-term listeners certainly are familiar with that concept. We've talked about that time and time again. But maybe for those who haven't heard the term lipidologies or lipidologists, could you define exactly what that entails, and what type of specialties go into to be board certified in
Sure.
lipidology?
Well, just think everything cholesterol and triglyceride related is lipidology. Lipidology is about the blood fats, and the major blood fats are cholesterol and triglyceride. Then you kind of go rings out from that. The next ring out is how cholesterol and triglyceride are trafficked in the body in particles called lipoproteins, and what that means for both health and disease. And then you get into the various things that can mess that up. And there's a wide range of stuff from other medical issues people have, such as diabetes or insulin resistance, to genetic causes, sometimes medicines they're taking. So it's a very rich area that you can simply say it's about cholesterol and triglyceride, but as soon as you start unpacking it, you realize whenever you see somebody, there are 70 plus potential things going on. What combination of the 70 does this person have?
Yeah. Now, most people who've ever been to a doctor or really talked to anybody about nutrition or been on social media, they've heard the term cholesterol. And historically, people used to say good cholesterol, bad cholesterol. We know that's not really a thing, right? It's really the particles that are good or bad in terms of how they interact with our physiology. But you've brought up the term lipoprotein a couple times. That's your Twitter handle for those who don't know, and I absolutely love that. Now, can you define a little bit what lipoproteins are and what purpose do they serve within our bodies?
Sure. So going back to cholesterol and triglyceride, these are fats, and these fats don't dissolve in water. So since our blood is mostly water, how would fats move in water without just being like a little slime layer on the top? And the answer is there are these lipoprotein particles. A lipoprotein looks like a tennis ball. It's got various fats on the outside. It's got proteins embedded on the outside, and the center is hollow. And what gets stuffed in the center are varying amounts of cholesterol, ester, and triglyceride. So lipoprotein particles are those things that move cholesterol and triglyceride to different places in our body for different reasons. Now, the interesting thing is that it's the particle that gets the letter name. So your viewers are very familiar with LDL, HDL. LDL is bad, HDL is good. But what that means is low density lipoprotein. That's what LDL is. So that's a type of particle that carries cholesterol. Um, as you said, there has been the nomenclature of good and bad cholesterol, but that's because cholesterol has been easier to measure than other things. And we have used the amount of cholesterol in an LDL particle as a way of quantifying things. Now, it's not 100%. We'll probably get into why it's not 100%. But that's where the term bad cholesterol came from, because it was a bad particle, LDL, and the cholesterol in a bad particle must be bad cholesterol. And if HDL is a potentially good particle, then the cholesterol in HDL must be potentially good cholesterol.
So let's do that now. Let's talk about a little bit more. What makes the LDL particle bad? What is it about the LDL particle that's quote unquote bad? What is it about the HDL particle? And then are there other lipoproteins, which is really what I want to get into, that might be more bad actors that we should really care about?
Well, that's a loaded question, and it could take us a little while to unpack it. So, good and bad actually come from the way in which these particles were first identified. So, you could ask yourself, when did we first know anything about human lipoproteins? And that was in the early 50s. John Goffman and Lindergan were the guys who characterized human lipoproteins. They did so with ultracentrifugation. They found that some particles were heavy and dense, and others were light and buoyant. And so they first categorized these by their flotation. High density lipoprotein was the more dense, then low density, then very low density. So these names actually were characteristics of the way they floated in an ultracentrifuge. The next observation was that if you look at the association of these particles with people who were having heart disease, there was clearly the case that a subset of lipoproteins were strongly associated with risk, and another subset was strongly associated with less risk. So those that were associated with risk are called the ApoB as in boy containing lipoproteins. ApoB is shorthand for apolipoprotein B. It's a structural protein that's on the outside of many populations of particles. The entire ApoB pool is considered potentially bad, and a high number of those particles, a large amount, would accelerate blockage formation. Now, what's curious about the ApoB pool is that over 90% of all ApoB particles are LDL. So it's not wrong to say that LDL is a bad particle, and it's not wrong to say that LDL particles are the key drivers of blockage formation. But to your point, they're not the only ones, but they certainly swamp out and dominate the ApoB pool.
There was a time where when we were doing that, I remember you mentioning that you on a different podcast that you had a partnership with Jim Otvos, right? Who came with or you guys together came up with the NMR profile, and they were measuring LDL particle number as well as the size of the LDL, which also matters. So I'd love to hear you briefly talk about that. And then I'm also noticing, at least both in mainstream and a lot of, among the lipidology folks, that LDL particle number is really not emphasized anymore in terms of what we're tracking, and ApoB is more favorable. When did that fall out of favor, or is there still a role to check for LDLP rather than LDLC instead of maybe, or is ApoB just good enough?
All good questions. So, little story. I was actually giving a lecture in Raleigh, North Carolina. I had some downtime, and the guy who was driving me around for the day said, "Do you want to meet a man who can measure lipoproteins?" Now, that's a trick because a lipoprotein particle is a mixture of phospholipids, free cholesterol, proteins, cholesterol, ester, and triglyceride. There's no chemical thing that makes one particle different than its neighbor. So, historically, quantifying a unique lipoprotein is very difficult. So, we went to an office and I met this tall guy in blue jeans and huaraches looking at NMR spectra. And I said, "What are you looking at?" He said, "I'm looking at these signatures from these lipoprotein particles." And we talked for a while, and I said, "So you can resolve the downfield shifts that are this close to one another?" He said, "Well, you know something about this." I said, "It doesn't seem like you should be able to do this." And so over several months, we had a lot of correspondence. And indeed, he had found one way to uniquely quantify individual populations of lipoproteins. And so we started working together, and the question was, would any of that information clinically make a difference? And how would we determine that? And the short answer is a whole lot of clinical trials. So now, 18 million samples, 700 peer-reviewed papers later, we learned a lot. And what we learned is that Goffman and Lindergan were right in 1952. And what they observed back then was that you could measure cholesterol or you could measure particles. If the measurement of cholesterol and the measurement of particles agreed, that's called concordance, and they both were equally associated with risk. But if the measurement of particles was different than the measure of cholesterol, discordance, risk tracked with the particles, not with the cholesterol. That observation has been true every time it has ever been looked at since 1950 in every people group, in every trial. So at the end of the day, it is the particle that is responsible for interacting with the artery wall to affect blockage formation. It is the number of particles that drive that process forward. And cholesterol is just a way to try to infer how many of those things you have. So when you ask, how do you measure the number of particles, you can do it by ApoB, and that's been around since the 80s. You can do it by NMR LDL particle number. That is another valid outcome-proven way to do it. ApoB had a good 20-year head start, so to speak. And so a lot of people would use ApoB, and that's fine. In my opinion, ApoB and LDL particle number are alternate measures of the number of particles. And either one can be used for good utility. It's a matter of what's available, what's easy for the practitioner to get. We have reports that embed both of those in our cardiometabolic report. Many more people get the ApoB version than the LDLP version, and that's fine. But it's just two different ways to get to the number of particles instead of relying on cholesterol to infer that.
I'm glad you brought up concordance and discordance. At least, as I mentioned, I'm a novice in this field, and at least over the last 2 years, I've had chat with at least 3 lipidologists, and at least one of them has mentioned that when we're looking at atherogenic particles, ApoB is really not necessary. And people at this point are thinking about their cholesterol panel when they get that. You have a marker that says non-HDL cholesterol. And at least the first person said, well, non-HDL cholesterol is a good proxy for ApoB. Both you and I know that that's a good proxy is not good enough when you can check all the atherogenic particles. But what I've come to learn is, especially in folks who have at least multiple factors of metabolic syndrome, that discordance becomes greater and greater. Would you care to just elaborate a little bit on that? Why a non-HDL cholesterol isn't necessarily the best thing to look at, and ApoB is truly what we want to track, if that's the marker you're going after instead of LDLP?
Well, so either way that you measure particle number, ApoB or LDLP, will be a definitive answer to the definitive question. How many of those particles do I have? When you're using something that's cholesterol based to answer the question, you run into a couple of problems. The first problem that you run into is that the amount of cholesterol in a particle is not constant. So let me show you an example. So I've got a bottle of water. Now, this bottle of water has not been opened. It says it's a 500 ml bottle of water. All right. So if I have 1 liter, I have 2 bottles. Simple math, right? So 2 is a half and a half. But what happens if I have a particle that looks like this? See, now the water inside is much, much less. And to get a liter with containers with this amount of water would be many more than to get a liter due to 2 full bottles. This is the dirty little secret of cholesterol testing. The amount of cholesterol per particle is highly variable. And it becomes more variable when you get into issues such as metabolic syndrome, insulin resistance, type 2 diabetes. There are physiologic exchange reactions that take place where cholesterol is taken out of some particles and given to others, and triglyceride takes the place of the cholesterol that was removed. And this two-directional exchange is done by cholesterol ester transfer protein, CETP. So what happens is, as you become more insulin resistant, metabolic syndrome, diabetes, high triglyceride, the characteristic of ApoB containing lipoproteins is that they become relatively cholesterol deplete. Not all of them, but most of them. So the amount of cholesterol in the particle has now gone down. That's why the LDL cholesterol and the ApoB or particle number can be discordant, right? Because I'm measuring the amount in an unknown number, but what's in the particle isn't constant. The second challenge is that total minus HDL cholesterol is the cholesterol supposedly in all the ApoB containing lipoproteins. But remember, I just said that under physiologic conditions, the amount of cholesterol in these particles is highly variable. And so when you look at diabetes or metabolic syndrome, you could ask the question, how discordant is 9-HDL from ApoB, or how discordant is 9-HDL from LDL particle number? And the answer is you can get up to 40% discordance in those settings. That's why 9-HDL, though it is better than LDL cholesterol, is not the same as knowing the absolute number of particles, especially in those settings where you have more cholesterol depletion, as we call it, or less cholesterol per particle.
Yeah, no, that's awesome. Thank you for that analogy. That really makes sense. So those who are watching will certainly get a chance to see that. This might be a bit too much in the weeds, but ApoB, as I understand it, there are at least ApoB 100, ApoB 48. When we're talking about the atherogenic particles and all the ApoB family, which one of those is it, and what are the differences?
Well, ApoB 100 is synthesized in the liver. It's on VLDL, all the breakdown products of VLDL, on LDL, and the breakdown products thereof. B48 comes from the gut, and it is embedded into a very, very large lipoprotein called chylomicrons. Chylomicrons are the way that we take fats and initially from the gut, package them, and send them into the circulation. B48 is very, very small as a contributor to the ApoB pool. We're talking about 2%. It's a very small contribution. So B48, while you may find it under certain conditions in atherosclerotic plaques, it is not a primary player. The ApoB containing particles that are much more injurious are the LDL particles, and there's a family of those. Remnant lipoproteins are very injurious, and remnants are the breakdown products in between VLDL that leaves the liver and LDL, which is formed after many breakdowns of VLDL through the remnants until it gets to LDL. Now, these remnants are usually cleared very quickly from the blood, but in the occasion where it is not, then you have a problem that they can rapidly accelerate blockage formation. And there are some unusual genetic disorders that are remnant abnormalities. They don't have an LDL problem. They have this breakdown product that didn't get cleared properly and it's hanging around too long. And as a result, this is causing blockage formation. So that's a little bit about B48, B100. And of the ApoB pool, it's the remnants and the LDL family, which are the worst actors.
What percentage of the population have that genetic variation where they're accumulating a lot of remnant particles? Do you have a sense?
Yeah, well, it's 2% have the genetic predisposition, and then a subset of that go on to develop the full blown syndrome. So, what we're talking about is dysbeta-lipoproteinemia or type 3 hyperlipidemia. That is a two-hit problem. The first hit is you have to have an abnormal ApoE. Apolipoprotein E is responsible for clearing remnant particles. There are major phenotypes of that or genotypes, and the genotype E2E2 happens in about 2% of the US population, and that's the setup for not being able to clear. The second thing that has to happen is you have to overproduce VLDL or very low density lipoprotein out of the liver. If you overproduce VLDL and you can't clear the remnants, that's what sets you up for persistent remnant elevation and blockage formation. So it's 2% have the genetic predisposition, and a subset of that go on to develop full-blown dysbeta-lipoproteinemia.
Wow. Yeah, we always hear about ApoE, particularly ApoE4, and its link with Alzheimer's. But I did, at least I remember reading at one point that ApoE is implicated in cardiovascular disease. So thank you for that, because now I can kind of wrap my mind around that. Now, the other lipoprotein that I think is really worthwhile for people to know, especially if you're of South Asian ancestry, which Darsh and I are here, is lipoprotein A. So could you talk a little bit about that? That's the other side of the family, right? But also maybe independent risk factor for MACE. So what is that? How is it different? And why is it important?
So low density lipoprotein, as I said, is a family of particles. And that family has different characteristics. You can have smaller ones and larger ones. You can also have those that have an extra protein on the outer surface called apolipoprotein small a. Now, that is a long protein that has several repeating Kringle units or circular things. It was actually named because I guess it reminds somebody of a Danish pastry. But you have these Kringle repeats in this long protein called ApoA. When that is attached to ApoB, it's like pin the tail on the donkey. And that particle has many attributes that make it much more injurious than just a regular LDL particle. So, how frequently do people have elevated LP-Little? Well, the most common reason for it to be elevated is genetic. As you said, Asian Indians are a ethnicity with many more problems with LP-Little than many other ethnicities. In the US, the frequency is about 20%. 1 in 5 individuals in the US has significant LP-Little elevations. We know from a number of studies that risk scales by quantity. And as you go higher and higher and higher, not only is LP-Little contributing to risk, but at some point it can be its own independent causal risk factor with no help from anybody else. And the thresholds that people typically talk about as being of interest, if you're using nanomoles per liter, it would be above 125. And then when you start getting over 150, 200, you're really picking up steam. And there's a population that significantly has a risk due to LP-Little. There are other reasons why it can be elevated, but you don't see it that often. Hypothyroidism can increase LP-Little. Renal insufficiency can increase LP-Little. Trans fat intake will increase LP-Little. So there are some other reasons for it to be high, but most commonly it's genetic.
Something vague comes to Darsh, comment on this if you remember. I remember Dr. Harkin mentioning that there was a study published somewhat recently that a vegetarian diet or a vegan diet can increase LP-Little. Do you remember that vaguely? Are you familiar with anything like that, Dr. Cromwell?
Those types of studies are small and they're hard to draw a conclusion. So we have a lot of signals out there, as I would call them. You have a population, they do a certain thing, there's a signal for change. Whether that's a significant association or causal is less than clear. But that's something that certain people are interested in.
Yeah, absolutely. So we spent some time talking about the atherogenic particles, rightfully so. Is there anything else that we haven't covered that you think is worthwhile for our listeners to understand and really advocate for themselves when they are looking at cholesterol panels, when they're considering their cardiovascular, stroke, just risk in general?
Yeah, I don't want to get us off topic too much, but just to introduce an idea, and that is that whether it be punitive lipoproteins like the ApoB pool, or hypertension, or diabetes, or any major causative risk factor, risk is a function of magnitude over time. How bad for how long? And this is critical. This is why people with familial hypercholesterolemia, born with very high LDL levels, end up with disease very early in life because they've been that way since birth. And they have been bathing their arteries in these increased numbers of ApoB particles, LDL particles. And it takes its toll over time. So the first question I have when I see somebody who has an abnormal value for ApoB or LDL cholesterol is, how long has it been that way? The longer, the worse. And many times we don't know. People oftentimes, especially men, they don't seek health care very frequently. Sometimes they only do because their wife shames them into the office. And so the wife has made you come to the doctor. Now you're 45 years old, you're getting your lipid panel, and it's abnormal. And you chase that with an ApoB, and it's high. And I say, well, how long has it been that way? Well, we don't know. Now you're left in a quandary. What do I make of this? Why is it high? How long has it been high? Are your vessels already demonstrating evidence of plaque formation? These are critical questions and get us into the precision medicine field. This is how we should be taking care of people one at a time. The three of us on this call could have the exact same ApoB and wildly different cardiovascular risk due to the duration, the magnitude, comorbidities, other factors. And this is where the guidelines have, over the past several years, made a little dog leg to the left. And that is, they've said, it's not good enough to calculate risk. It's not good enough to try to make a number go from A to B. You really need to know much more about an individual. And so this includes their clinical history, their biometrics, their biomarkers, 30 plus risk enhancing factors. You're supposed to integrate all of that one person at a time and then harmonize it with 6 different US and international guidelines. Now, when you do all of that, then you come up with so here you are. Here's what I can tell you about you. And this includes things like Lp(a) and ApoB, but it also includes, do you have autoimmune disease? Do you have chronic inflammatory disease, RA, psoriatic arthritis, ankylosing spondylitis? Do you have HIV? If you're a female, did you have premature menopause before 40? Did you have preeclampsia during a pregnancy? I mean, the number of risk enhancing factors is very, very, very broad. And that's the way that you bridge the gap between, here's my number and what do I need to do about it?
So the logical question becomes, in your ideal practice, when would you first check these markers? Teens, 20s,
Yes.
earlier?
So this is now getting a lot of steam in preventive cardiology. Alan Snyderman, who is a senior of mine, he's the guy who came up with the term hyperbeta lipoproteinemia in 1984 with Pete Quittervidge. So he's the godfather of ApoB and atherogenic particle number. And Alan, for years, has advocated, if we have a punitive risk factor, the sooner you find it, the sooner you can fix it. Now, we said that risk is magnitude over time. Benefit is how much improvement over time. So if you can make a significant improvement at an early age and keep it, the decades of improvement are what act like compound interest to give you the best outcome. So small changes earlier in life and sustained have great impact on long-term risk versus finding people later on, 50s, 60s. We can still do something to help them, but a window that we could have done a better job would have been in their 20s. So finding people earlier in life is critical. And when you find them, you want to at least make sure that you have evaluated alternate reasons why the numbers could be bad, things like liver disease, renal disease, kidney disease, thyroid disease. You want to make sure that they have an appropriate therapeutic lifestyle, diet, exercise. You want to make sure that they're trying to maintain a reasonable weight. You're doing these things that, short of medication, could have a big impact. And then as they go along, if you happen to run into these risk-enhancing factors in abundance, that's where you're supposed to have a shared conversation with the patient. And you and the patient talk about it and say, if I leave you the way I find you, your long-term risk is relatively high. If we do something to mitigate the factors that are causing some of that risk, we have the potential for benefit. But success is promised to nobody. Failure is promised to nobody. I can't write it on a rock that somebody's going to have a heart attack at a given time. But I can say The first step in deciding who a good candidate for medical therapy is, ask yourself the question, what happens if I don't do anything? What's the natural history of leaving people the way you find them? And if I have a 30-year-old with a family history of early disease, high Lp(a), high ApoB, and I leave them that way, I am leaving them in the sandbox of atherosclerosis for them to get more disease than they need. And that's not a reasonable thing to do.
Now, while we're on the topic of risk, I was curious to know whether there are other tests that we could do within the lipidology world that would help us understand disease states. For example, LDL receptor count, maybe. Right? We know that if you take statins, what we're doing is clearing the LDL by upregulating those receptors. So aside from just starting early from a prevention standpoint, getting a lipid panel, maybe getting the ApoB, LP little a, as well as the intervention from a lifestyle perspective, is there anything that we know of that can also help elucidate whether somebody would be at a higher risk moving forward that might not hit them, in their teens or 20s, but maybe when they're 40 or 50?
Yeah, that's a great question. And it goes back to risk enhancing factors. So this is where the guidelines say, we have equations that were developed in order to take a population and stratify them into big buckets, high, moderate, low risk, let's say. And that's a nice way to segregate people, but within each bucket, there's a lot of heterogeneity. So not everybody in the high risk bucket is truly high risk. Not everybody in the low risk bucket is truly low risk. So how are you going to try to do a better job? You're going to look for the factors that have, as part of their physiology, they play in the sandbox of making a blockage. So the things I was just going through with you, which include chronic inflammatory diseases, etc. These are all things that once you start finding multiple risk enhancing factors, I have found the individual who needs a close look, who needs, if necessary, pharmacologic intervention to reset their ApoB level to a place where they are less likely to develop blockage. Now, the corollary to that, and one that has also been very important in the past 5 years in preventive cardiology, is imaging. If I image your vessels non-invasively and I find plaque, I have found disease. I don't have to worry if we're about to start something, you already have it. And that puts a sense of urgency in getting everything that's modifiable to an optimal place. So existing blockage would be stabilized, new blockage would be slowed down or stopped altogether. And so how one images is its own conversation and topic, but increasingly imaging is part of the discussion of, you come to me with a number which is unfavorable, we don't know how long it's been there, we haven't found a secondary reason for it. My next question is, what's up with your vessels? Do you have plaque? Yes or no? I don't need flow limiting disease. I don't need an abnormal stress test. I don't need something ready for a stent. All I need is objective evidence you have plaque. And if you have plaque, and I do this with the guys, it's funny. So guys come to my practice, kind of shamed again and by the wife many times. And we go through this workup and I find blockage. And so the guy's looking at me and saying, well, okay, you got this imaging study and you say there's plaque. So what does that mean? So, well, I want you to practice saying this. What's your name? Say the guy's name is Bob. My name is Bob, and I have vascular disease. So, oh, that's harsh. No, you got to say it to me. I got to hear it. Because until you own it, you can't fix it. Because the wife is going to say, what doc say? Doc said, my name is Bob, and I have vascular disease. Wear it proudly so we can fix it. If we can't find it, we can't fix it. If we don't own it, you're not going to keep it fixed. So first step is, we got to find it, and then I got to get patients to admit that this is something where I could leave you the way I find you, which is with disease, or we can do something about it. Another way to put it sometimes, when people aren't getting it with that, is I tell them, your house is on fire. Now, it may be confined to the closet in your bedroom right now, but there's a fire in your house where it's not supposed to be. You'd probably like to put that out, or you can watch your whole house burn down. It's up to you. And so they kind of get it, like, you're talking about real stuff here. I'm talking about a vessel that's got blockage in it, and you can either let it grow and misbehave, you can stabilize it, but the choice is yours.
Now, the imaging that I imagine you're referring to is either a CAC, CT angio, or non-invasive ultrasound, right?
Yeah.
Anything else that I missed there?
Those are the non-invasive imaging techniques along with ABI. So ankle brachial index is a means to check blood pressure in the arm and the ankle. And if it is a low average of less than 0.9, you infer there to be decreased flow. That's a good screening test. It's not a definitive test, but for many people, that's another way that you can non-invasively begin to, steer toward an answer. Is there evidence of something that needs my attention?
So since we brought up Snyderman, and all of us are interested in the preventative aspect, right? Dr. Al Snyderman talks about the 30-year risk, right? Which is, again, stuff that we're interested in. The ASCVD is really looking at your 10-year risk marker. Darsh and I were not 40 years old, so it doesn't even qualify. We can't even put our numbers in there. But what would you, let's just say that person that you used before, somebody in their 30s, high Lp(a), maybe borderline to high ApoB, some risk enhancing factors, other risk enhancing factors in terms of ethnicity and whatnot, what would be the non-invasive imaging modality of choice? Would it be CT angio, ultrasound?
So, good question. I would add one thing before I answer that, and that is that the risk calculator can give you a lifetime risk. So, you have 10-year risk and lifetime risk. And so, even at your age, you can get an estimate of lifetime risk. For men, if it's elevated, if it's high, you by definition have high risk. A colleague of mine, Sergio Fazio, once said, "You're never lower than your highest risk." So, if you calculate your 10-year risk is low and your lifetime risk is high, you're never lower than your highest risk, which means you're high risk if we just leave you the way we find you. So thanks for bringing up the age component of long-term lifetime risk as being more meaningful than 10-year risk in individuals under the age of 50. Okay. Now, when you're in the age group that you talked about, 30s, maybe early 40s, if you have access to high quality B mode ultrasound of the carotids that can quantify plaque, that's a very good imaging study. But it's very operator dependent. So the person doing the ultrasound has to do it well. They have to take their time. They have to freehand through the bulb and the internal carotid to find areas that look thick. Then you have to measure it, and then you have to measure it in multiple different planes of image acquisition. And ultimately, you're looking for confirmation that there's something reproducibly 1.5 millimeters or greater in thickness. And if you have that, you have a plaque. That is much more sensitive than a CAC score. So a CAC score, coronary artery calcium score, detects calcified blockage, but calcification occurs late. So you can have a lot of different blockages that are not calcified, a zero calcium score, and you end up saying, "Oh, I'm good. I have a zero calcium score." The other test you mentioned, a CTA, is like a virtual angiogram, and you can see the plaque, even though it's not calcified. Many, many different series out there have taken cohorts of people with a zero calcium score and then submitted them to CTA and found lots of disease. So a coronary artery calcium score is best for individuals who are a little bit on the older middle age side. So men 45, 50 or older, women 55 or older. That's a good place for you to consider CAC scoring. In the 30s, CAC scores are just a gate that swings one way. An abnormal number gets you noticed, and a zero value doesn't rule anything out. Because of the radiation exposure and whatnot, CTAs are probably not a great first step for young people. They can be done for good indications. But in my hands, if you are able to do a high quality B mode ultrasound and demonstrate plaque, that's very valuable.
As someone who does a lot of ultrasound in the musculoskeletal realm, yeah, the operator dependent piece is critical. And I try to explain that too. And I guess the challenge would be is how do we identify what high quality or who the operator is and how good they are? Any tactics on how somebody can tease that out? Is it just really word of mouth or any other way for us to know?
It's not easy. So that there aren't metrics out there and there aren't societies out there that you can go look up a center or a tech or a physician and say, where do they land? I would ask a few probing questions. Number one is carotid ultrasound can be done as a B mode or as a duplex scan. A duplex scan is looking for flow velocities. How quickly is the blood flowing to different spots? And they'll get spot, 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 spot. And they're looking for a change in velocity, a gradient. And that would infer that there is a blockage that is limiting blood flow there. So if you're using duplex scan, you're getting a relative potential plaque assessment. They may say 0 to 25%, 25 to 50%, but that's not really measuring plaque. It's measuring a phenomenon that could be related to a plaque. If you look at B mode ultrasound, you can do what's called a carotid intima media thickness test, CIMT. And what you're doing there is you're looking at the first two tissue layers, the intima and the media, in the distal common here. And what that will tell you is how thick are you compared to age-matched peers. That also is not the same thing as a plaque. Now, if you're doing a B mode ultrasound and doing a CIMT exam, you can also look at the bulb where the internal, the external, and the common carotid all come together. And you can look in there to find cross-sectionally and longitudinally any areas that are thick. You can do that in the internal carotid. And so many times people do both a CIMT and a plaque assessment in the same study. And the questions that you could ask if you're interested, if you call somebody and say, call hospital X, do you do B mode ultrasound? Yes, I do. Do you report plaque in millimeter thickness? And there's a pause. You either do or you don't. If you report plaque in millimeter thickness, then you are actually looking for evidence of what we would call 1.5 millimeters greater thickness plaque. If they say, no, we don't report plaque in millimeter thickness, then that's not the same quality of the exam. So that's one discriminating question that could help you as you're looking for a center. If they say, oh yeah, we report plaque if it's there in millimeter thickness, that's a much better place to start.
Love that. Thank you for that. Now, this might be a silly question, so pardon me if it is, but what's the logic behind only checking the carotids, right? Somebody could be absent of disease from carotid arteries and still have coronary disease, right? And be more susceptible to heart attacks versus strokes. Is that the case? Or if you have any atherosclerosis, carotids is the first place it's going to be, or something like that?
Yeah, so disease anywhere is the same as disease everywhere. For the purpose of saying, do you have plaque formation, any arterial bed that can be shown to have definitive plaque gets you checked into the box of, okay, the process has started, we need to turn it off. Now, we learned a lot about this from the Bogalusa heart study back in the 70s in Bogalusa, Louisiana, where they were doing carotid ultrasounds in high-risk teenagers, and they were finding plaque in high-risk teenagers. So we know that this is a methodology which is particularly sensitive at a younger age, and that's the reason why in 30-year-olds, if there's something there, you're likely to see it. You also made a good point that every vascular bed is its own time clock and its own independence. The problem with coronary arteries, not only are they very small, but they are sheltered under bone and muscle and all sorts of layers of things. Being able to visualize that is very difficult. You're not going to see it with ultrasound. You're going to see indirectly the calcium in a plaque by CAC score. And really, CTA is one of the few ways that you're non-invasively going to be able to see details of a plaque without actually doing an invasive cath. Now, there are things you can do if you do a catheterization, but nobody wants that for screening.
Yeah, certainly not the first step. I want to come back to HDL for a moment. It's we touched on in the beginning talking about good versus bad cholesterol. Hopefully, we've dispelled that, and we've certainly talked about that before. But often people will go to their providers, whether primary care or cardiologists, and they'll say, "Look, your HDL numbers are high. You're doing really well. That's protective. That's cardioprotective." I think we've all known that for quite some time. But the problem is trying to raise that, intentionally hasn't really panned out as well. So can you talk a bit about HDL and how that turns out to be protective rather, and then why haven't we been able to manipulate it, or why haven't the outcomes improved after we manipulated it?
So this could be a whole day's conference. HDL is complicated. ApoB is easy. ApoB is bad. A lot is real bad. Don't have a lot. HDL, on the other hand, is complicated. If you look at our understanding of HDL cholesterol, it first came out of things like the Framingham Heart Study. And what they found was that individuals with low HDL cholesterol were at significantly higher risk of vascular disease, and that people who had higher HDL had lower ASCVD risk. So that kind of made sense. The problem was that what was considered high in the early studies was up to about 80 to 85. We really didn't look much past that. What has happened over the past 15 to 20 years is there have been very large populations which allow us to see people that are higher than 90, 95, 100, 105, etc. And what is true, and I just did a grand rounds on this not long ago, The higher the HDL, at some point you not only are not cardioprotected, but it's associated with increased events and increased mortality consistently. So high HDL is not only not going to buffer your LDL, high HDL, when you get into the hundreds, is going to potentially put you at increased risk. Now, how can that be? How can a particle that's supposed to be good put you at risk if you have a greater than expected amount of it? Because what's really happening with HDL are the functions that HDL carries out more than the quantity of cholesterol in the HDL or even the number of particles. There are ways in which the HDL particle can be a good actor or it can be a bad actor. So to make it simple, the HDL particle has about 100 plus proteins on the outer surface. It's a proteome. It's got all these proteins. And these proteins do a variety of things. Reverse cholesterol transport. They pick up cholesterol from other tissues like macrophages and get rid of it so that you can decrease blockage formation. Anti-inflammatory functions, antioxidative functions, anti-infective functions. There are all sorts of things that these HDL particles do. And what we know is that those complex functions are highly modifiable. They are specifically modifiable when there are comorbidities such as diabetes or when there's high systemic inflammation. Many elegant studies have directly shown, for example, that you can take human aortic cells and you can put a constant HDL quantity in this media. And as you increase the amount of inflammatory substrate, you directly decrease HDL function. You no longer have endothelial nitric oxide production. You have increased free radicals. You increase adhesion cell molecules like ICAM and VCAM that start the process of recruiting monocytes to become macrophages that start the blockage formation. So take away from this that the function of the HDL particle is the more important entity. And we don't have any commercially available test for HDL function. It's a research tool still. But that's what the future of HDL therapies may look like, is how do we, one way or another, improve a meaningful aspect of HDL function, such as reverse cholesterol transport. And there are studies of agents that are ongoing now. But to your point, bulk raising of HDL with niacin, with fibrates, with CETP inhibitors has never demonstrated clinical benefit. And that is because it's not the bulk of the HDL that is going to confer benefit or risk. It's the function of the HDL.
Awesome. Well, yes, it's a complex topic, but you've distilled it to some core concepts that I think hopefully people can take away. I certainly feel a little bit smarter, but I'm sure there's a lot more under the surface that we haven't been able to touch. I want to switch to triglycerides, and I think that'll bridge really well in talking about metabolic syndrome. We've talked about a lot of different lipids and atherogenic particles. Triglycerides is another marker that ties into metabolic syndrome, sign of inflammation, and just long-term adverse outcomes. Can you talk about triglycerides a bit in terms of how are they distinct from the other particles that you talked about? I know the lipoproteins will carry them, but what is their role specifically, and how are they a proxy for just overall metabolic ill health?
Well, so triglyceride abnormalities are complicated. And most commonly, what you're talking about when you see high triglycerides is either you're producing too many triglyceride-rich particles, you're not clearing the particles after you make them, or both. So to talk about high triglyceride and what's happening and why it's bad, you have to think about production and clearance. Overproducing particles occurs, for example, in insulin resistance, metabolic syndrome, type 2 diabetes, where you are flooding the liver with free fatty acids and building blocks for triglyceride. And as the liver is a master carpenter, it's taking these substrates, it's making lipid, you package that into a VLDL particle, which is triglyceride rich, and so we're overproducing, and that shows up as a high triglyceride. Now, the clearance of triglyceride is through enzymes called lipases, and lipases chew up the triglyceride inside a particle, much like air leaving a balloon. As the triglyceride is liberated from the particle, it shrinks in size, like air leaving a balloon. And this is how you go from a VLDL particle to different remnants, all the way down to LDL. So what's happening in real time when you see a high triglyceride is some amount of production, some amount of clearance, or a problem with both. And that gets us into understanding, well, why is triglyceride a signal for risk? Well, when triglyceride is high, many things are happening. The first thing that happens is the amount of cholesterol in the particle changes. This is what it looks like with a normal triglyceride. This is what it looks like with a very high triglyceride. So as triglyceride goes up, the cholesterol in LDL goes down. Your measured LDL cholesterol looks okay. But because you are overproducing these ApoB particles, your ApoB is actually high. So now we have this discordance again. We have too many of the bad particles. The triglyceride is changing the composition of the LDL, so you don't see that the LDL is really high when it actually is. And so one of the things which commonly happens as triglycerides go up is that there is an increase in the number of ApoB particles, which is directly atherogenic. And that is a large part of triglycerides' relationship with risk. It's not all of it, but it's a large part. The second part, as you said, are the more dynamic physiologies that have high triglyceride as part of it. Insulin resistance, metabolic syndrome, diabetes. And that's a very, very early finding. If you look at all the things that go wrong with people who are trending toward metabolic syndrome, it's abnormalities of lipoproteins that predate even a rise in insulin. And specifically what happens is you have increased numbers of large VLDL particles, increased numbers of small LDL particles, decreased numbers of large HDL particles. And when you put those along with the sizes of these particles into a multi-marker called the lipoprotein insulin resistance score, the LPIR score is highly predictive of future diabetes, independent of glucose, independent of insulin, independent of waist circumference, independent of triglyceride, independent of triglyceride HDL ratio. So many of these biomarkers overlap with the condition that they are giving visibility to. When triglyceride is high, it's giving visibility to, in many cases, metabolic syndrome, insulin resistance. But there are so many other things that are also pointing in that direction that you have to ask, is triglyceride a marker or is triglyceride a mechanism? And we have more data to say it's a marker than to say it's a mechanism. The mechanism side is when you have these remnant particles, right? So when remnant particles are high, triglyceride is up, you have type 3 dysbeta-lipoproteinemia. Okay, there's a direct causal relationship. But outside of situations like that, triglyceride is more of a marker of disease and specifically commonly found in metabolic syndrome, insulin resistance, diabetes.
It's very interesting. I think as we learn in medical school and then intern year and onwards, when we look at metabolic syndrome, we really look at it from a checkbox perspective. If you hit the blood pressure, if you hit the waist circumference or the fasting glucose, we're just going to check it off. And if you have, 3 or more, we're going to bucket you into the metabolic syndrome. Well, you're saying that there is a difference between what causes those markers versus, the risk that brings those to kind of come up from an inflammatory standpoint. Do you mind touching on, especially from your company PHR standpoint, some of the markers that you're checking to assess that risk to see if a patient is on the trend to metabolic syndrome and the importance of those?
So that's a good segue. We have this categorized mentality about metabolic syndrome. 3 or 5 features or more, you've got it, right? Now, the interesting thing is what happened long before any of those features came out is that you had this perturbed metabolism with the lipoprotein insulin resistance score as a very early proximal sign of insulin resistance. Now, you could also look at insulin levels. Insulin levels will rise with insulin resistance, but it's a lagging indicator behind lipoproteins, but it's still relatively early. You can do a HOMA insulin resistance score, which is a mathematic combination of insulin and glucose, another way to infer insulin resistance. So there are several ways to infer that. If all you had was a lipid panel, triglyceride divided by HDL cholesterol, over 3 to 3.5 infers insulin resistance. So there are many ways to infer insulin resistance. I think the question that you were getting to is, what can we do to discriminate the risk for diabetes, heart attack, and stroke that people have in the insulin resistant state? So let's say the 3 of us on this call all have 2 of 5 features for metabolic syndrome. Does that mean that we have equal diabetic, heart disease, and stroke risk? And the answer is no. Well, what's a better way to discriminate? And one way to do that is called the Metabolic Syndrome Severity Score. It was developed by researchers at the University of Virginia and the University of Florida. And what they did was, with access to large, well-weighted data sets, they said, let's take the absolute value for your waist circumference, your triglyceride, your HDL cholesterol, your glucose, and your blood pressure, and create a multi-marker which will weight these things and give you a continuous variable from 1 to 100. And what you will find is that when you're above the 75th percentile, you're significantly increased risk for diabetes, heart attack, and stroke. I will tell you that we have that in the Precision Health Report Cardiometabolic Risk Report. I have seen so many examples of people with 1 or 2 factors, 60th percentile, 2 or 3 factors, 30th percentile. So the number of categorical features you have does not bear resemblance to the impact that the actual numbers have. So the bucket categorization gets you in the right direction. You need more detail to unpack the contribution to risk of these individual markers, like metabolic syndrome severity score. And if your specific question is, what is my risk of diabetes down the road? The curious thing is that the lipoprotein insulin resistance score, as I said before, is uniquely robust in determining incident diabetes. We did all 26,000 of women's health study. It was not made inaccurate or non-predictive by adjustment for the entire kitchen sink. You adjust for waist circumference, BMI, glucose, insulin, etc. It still predicts. That's true in Prevent, it's true in Cardia, it's true in Mesa. So if the purpose is, what are my cells doing? Insulin resistance score. How is my body doing? Metabolic syndrome severity score. What's my diabetic risk? Glucose, LPIR score. And if you look in Mesa, for example, the multi-ethnic state of atherosclerosis, we have a cohort of otherwise healthy, well people followed for a very long time. A certain number of them developed diabetes. Well, that's very interesting. So how can I predict who did or who did not? Well, the reason that we transition from normal glycemia to diabetes is that as we become insulin resistant, our body increases insulin production, right? So if the liver, muscle, and fat cells are not responding to an insulin signal, just repeat yourself. If your child didn't take out the garbage, just repeat yourself. Sooner or later, it's going to happen, right? Just keep repeating yourself. So insulin levels are going up. We are compensating for the lack of peripheral sensitivity, it's peripheral insulin resistance. Glucose gets to some number, usually between 100 and 110, and it hangs there for a really long time. And as we continue in this insulin resistant state, eventually our pancreas begins to decrease its insulin production, and glucose, like a hockey stick, rises very precipitously, right? So that's the pathophysiology of what's going on between normal glycemia, the diabetic threshold, and insulin resistance in the middle. So if I were to plot for men and women separately, what does your diabetes look like as a function of your glucose? I got an 80, a 90, 100, 110. Well, let's pick 110. At 110, you can have either an ideal insulin resistance or you can have a maximally high insulin resistance. And what I'm doing with my hands demonstrates the difference in risk at any different given glucose. Wherever your glucose is, your actual risk of progressing to diabetes is how insulin resistant are you at that glucose. The more insulin sensitive, the less. The more insulin resistant, the more. And to put some numbers to this, you might range from a 10% 8-year risk to a 45% 8-year risk. That's huge. And if I tell you specifically, given your numbers, you're at 40% risk, you can do something about that. You can change diet, lifestyle, etc., and you can bring that risk down. How do we know that works? The Diabetes Prevention Project. In DPP, using lifestyle, there was a significant reduction in people transitioning into diabetes. And what was the most predictive marker of who did not develop diabetes? Change in LPIR score.
Love that. Now, I've had the chance to take or use my own report and look at some of the different markers, all the ones that you're mentioning to me. I actually went through all that this weekend, so it's all fresh in my mind. But One of the things that was somewhat new to me was the systemic inflammation, right? Historically, we've talked about high sensitivity CRP, how that's a good marker, but you guys use something called glyc A. Am I saying it right? Or is it glyc A? I don't know, GLYC. Do you care to just talk about why you guys favor that over HSCRP?
So we're talking about systemic inflammation, and total body or
Mm-hmm.
systemic inflammation can occur for any number of reasons. But at the end of the exercise, the liver is producing a family of acute phase proteins. And these acute phase proteins include things like interleukin 6, interleukin 1, high sensitivity CRP, haptoglobulin, a whole bunch of them, right? So we have all of these acute phase inflammatory proteins that are being released, and they can be looked for. HSCRP was one that was of interest to Paul Ridker and others. It was very well characterized. We know the story of HSCRP and its relationship with risk. But the challenge with that as a biomarker is its biologic variability. So if you look in the same person over time, there is a significant biologic variability day to day, week to week. If you are going to use that biomarker, you're advised to do more than one and average them in order to get a more representative measure. There's a gender bias with higher HSCRP in women versus men. So this is a biomarker that's a little clunky and doesn't lend itself to the degree of reproducibility that would allow it to be used as a single test and with one blood draw. How's my inflammation? That's just not what HSCRP allows you to do. Glyc A is an NMR signal, which is the composite of 5 to 7 different acute phase proteins. And because it is the integration of multiple acute phase proteins, its biologic variability is less than 5% versus HSCRP, whose biologic variability is over 40%. There's no gender bias. When you look in populations like Women's Health, or you look at MESA or others, the performance of these head to head, glyc A outperforms HSCRP. If you look at some specific examples of outcomes like mortality, glyc A is a much better predictor of mortality. If you ask the question, what about on statin therapy? And in the Jupiter study, your viewers may remember, Jupiter was a study of rosuvastatin versus placebo. And it was particularly helpful because the rosuvastatin group got so much benefit, they stopped the trial early for clinical benefit, right? Now, that doesn't mean that everybody on rosuvastatin was protected. Some people on rosuvastatin went ahead and had a heart attack anyway. Did HSCRP discriminate people who developed heart attacks or not on rosuvastatin? It did not. Did glyc A? Yes, it did. So glyc A is a more stable biomarker that only has to be measured once to be accurate. It doesn't have a gender bias. It outperforms CRP in disease associations with mortality, diabetes, heart attack, stroke, and it specifically gives a unique read in people who are on statin therapy regarding residual risk. So that's why we chose it.
Love it. Well, Dr. Cromwell, we spent an hour talking about diagnostics. I'd love to switch, if you have a couple more minutes, to talk about management strategies. I think that this conversation won't be complete unless we do that. And the best place probably to start is to talk about lifestyle interventions. I know we touched on that earlier on, how that's probably going to be where all of us are going to start. And this piece is interesting because anybody and their mothers really will come in and talk about nutrition and sleep and just feel that they're a subject matter and these experts. And it's when I look at the literature, it's very muddy to me in terms of which one of the levers is the best to pull on. I also understand that context is everything. So for what might be the best lever for Darsh might not be the one for me, it might not be the one for you. But I suppose when you look at the data, right, you've been doing this for 30 plus years, longer than that, which one of those lifestyle intervention, and I put that in quotes, levers, is the place to start pulling in order to make significant changes in somebody's atherogenic lipid particles?
So you teed it up correctly, and it depends on the physiology we're talking about. Different physiologies respond to diets differently. So if we start with the elephant in the room, insulin resistance, metabolic syndrome, these individuals benefit more by a therapeutic lifestyle diet change than they do from exercise. Both are helpful, but the diet is more important. And what part of the diet has been shown to be most impactful? Some version of carbohydrate capping, some version of intermittent fasting, some version of calories to maintain ideal body weight. So there are three characteristics that would be the ideal diet for an insulin resistant individual. Carb capping does not mean that you have to be ketotic, and that's very controversial. There are people who will look at keto diets as potentially helpful for a variety of reasons, and that is true. But keto is a principle, and there are many ways to try to carb restrict and be in a keto diet. If you were to overeat certain fats as a percentage of calories, many people go on to have very high LDL, which is unproductive. There was even data at ACC that indicated that individuals on a keto diet with high LDL have increased atherosclerotic event risk. So it's not benign to do that. So you want to cap carbs, but you don't want to go full out to the point that you're getting deleterious effects on ApoB and particle number. I have found that a 75-gram carbohydrate cap is a good starting point. A lot of people can operationalize 75 grams without really finding it too difficult. But that's just a number. That's a target. It doesn't have to be 75. It can be 50 to 100, anywhere in there. But it doesn't have to be a keto diet either. Intermittent fasting. There's a lot of very good data that an 8-hour eating window followed by a 16-hour fasting cycle with no calories has significant impact on insulin resistance and heart attacks. Now, again, some people will do great with an 8-hour window. Some people need to go to a 6-hour window. Some people even want to go to a smaller window. It's just harder to do, right? But those are things that many people haven't ever tried. So keeping your total carbs at 75, stepping your way into the point where you're having your first calorie intake between 10 and noon and cutting off between 6 p.m. and 8 p.m. That's a good 8-hour window. And then you operationalize that. And the next thing is, in combination with exercise, tune your calories to maintain an ideal body weight. On the exercise part, it's basically time under tension and high intensity interval training that have the best insulin sensitizing effects. And your viewers are probably familiar with those, but I use time under tension a lot for people who are somewhat limited in what they can do, right? And the concept is, let's just take a squat, for example. If I do a squat, I go down, I come up. Well, time under tension is I take an 8 count to go down and an 8 count to come up, and I never release the tension, and then I go back down for an 8 count. So it's keeping muscles under tension for a longer time. If you're in the gym and you're doing bench press, go with a lighter weight and then start with it off your chest so you still have a load. 8 count out, 8 count back, don't let go of the load, and repeat that until you either hit exhaustion or you've gone 30 seconds, right? So time under tension and high intensity interval training are really very helpful in improving muscle insulin sensitivity.
Love that. I did want to ask about lean mass hyperresponders, and I know this could be a whole nother conversation as well. But you did mention people on keto diets. Sometimes they will see their particle numbers jump up. Can you just briefly explain what the lean mass hyperresponder means and any type of comment that you have on it for people to kind of learn and to be aware of?
Well, it's a term that was used by David Feldman to give a monocle to people who, on a keto diet, had a low triglyceride, a higher HDL cholesterol, and their LDL cholesterol, particle number, and total cholesterol went up decidedly. And it can go very high. It can go over 200. It can go over 400. I mean, it can really, really go up there. So this phenomenology of people who are lean and on a keto diet are having this type of lipid change has been called a lean mass hyperresponder. As I said, there are data sets out there that would indicate that on a keto diet, high LDL over time is associated with increased event risk. There is a study going on now looking at arteries to see what happens with imaging of arteries over time in people who are so-called lean mass hyperresponders. The key thing is that persistently high numbers of ApoB particles is potentially dangerous. It does not have associated with it a benign characteristic. And I think one of the things you have to be very, very careful about is the persistence of that for a long period of time. Now, let's say that you're a lean mass hyperresponder and you jumped up and then over time it comes back down. That's fine. Let's say you jump up and you change your macros and it comes back down as you adjust your macros. That's fine. But to have it go up and stay at a really crazy high level and say, that's fine, I think I'm okay for the next 20 years like this, we have no data and we have no model of anything like that that would support that it's a benign condition to maintain numbers like that for a long period of time. So there are people who are trying to get a better understanding of when and how things go bump in the night that way. But I would simply say, if one of your viewers finds themselves as lean mass hyperresponder, a couple of things to think about. Number one, non-invasive imaging. Do you have plaque? If you have plaque, don't feed the plaque. ApoB is wood that you put on the fire of atherosclerosis to watch it burn bright. Don't feed the plaque. Number two, if you don't have plaque, that doesn't mean that you are clean. It means that this is also a potential factor going forward, and you need to keep an eye on it. You need to do serial imaging studies or something else to detect when a change is occurring so you don't let things get out of control, right? Number three is, what's the value in maintaining an ApoB that's super high if you can just simply change your macros a little bit and bring it down to a more modest range? You're still having keto principles. You're still on a carb-restricted diet. You're still ketotic. But by changing the macros to keep the ApoB less daunting, you're benefiting and you're not losing anything. So the people who are resistant to changing anything and believe that maintaining high atherogenic particles for a long time is innocuous, I feel uncomfortable with that.
Yeah. I think it's important to note for the listeners that all the things that we're talking about in terms of markers and risk tracking, we're, as you mentioned, we're looking at ApoB and the LDL particles, the things that are going to be atherogenic. The other thing that we did talk about earlier is Lp(a). And selfishly, this one is super important to me. It's somewhat frustrating because there's really not a lot out there, at least that I'm aware of, in terms of how do we work with these folks, or how do we talk to the people in terms of interventions who have an elevated Lp(a), right? And especially that threshold that you mentioned above 125 nanomoles per liter. What type of medications? I understand PCSK9s. There's some ASOs that are kind of in the pipeline, but let's go back to that 30-year-old, 40-year-old is really not going to qualify for those agents just because in the clinical trials, it's going to take decades before that's even valid. And I even think about, well, let's say if we try to address residual risk, ApoB in particular, there is some evidence to suggest that statins actually paradoxically increase Lp(a). So I'd love to get your thoughts on what do you do in that type of conundrum, and is statin still an approach that you'd like to take, despite the fact that it might increase Lp(a) if you're tracking it? How do you handle that?
Well, so there's a lot in your statement and your question. So starting with what can we do to lower Lp(a)? PCSK9s will lower it, but over a highly individual range. You could say average 25 to 30%. I've seen some people who have had a great response to PCSK9s. I've seen some people who have had no response to PCSK9s. And so there's a wide range of individual variability, even with that as an example. Niacin at high dose can reduce Lp(a), but it doesn't give cardiovascular benefit on top of a statin, so it's not something which is commonly used. Statins can, in certain cases, raise Lp(a), but not by an amount that would be problematic. And if you look at outcome studies of individuals on statins, those who have an Lp(a) elevation continue to have cardiovascular benefit on a statin. So I don't think statins are contraindicated in people with an elevated Lp(a). To the contrary, we use all the tools available to us to bring the ApoB pool, including Lp(a), down as much as we can. And one of the things that we haven't talked about specifically, but it tees up with this conversation is, what would you reach, or what is your goal for an individual with high Lp(a)? What number are we trying to get to at least keep the company that Lp(a) is keeping in a better place? Short answer is there's no too low ApoB or LDL. There is no too low. If you have an LDL cholesterol and PCSK9 of 20, God bless you, keep it there. Do not back off. Why do we say that? In the Fourier study, 13,500 individuals on statin plus placebo, 13,500 people on statin plus Repatha. If you compare them, the group that had statin Repatha had a median LDL cholesterol of 26. 26. Many of them below 20, and they were left that way for years. What did that teach us? It taught us that as you continue to drive LDL and ApoB down, there is more event reduction. There is no level below which further reduction doesn't give you additional decrease in heart attack and stroke. Number two, there were no more adverse events in individuals in the 20s than those at 50, 70, or 100. They had no cognitive dysfunction. They had no difference in safety signals. There was no safety downside. And this is why all of the guidelines have transitioned from a stopping point, a goal, to a threshold, a starting point. Right? As the guidelines are now being harmonized, we want people to stay as far below their threshold as possible. Let's take a very high-risk person who has a high Lp(a) and they already have blockage. Well, the minimum threshold that's harmonized now is less than 55. And as far below that as I can get is where I want to be. You give me Lp(a), if I can get you down to 30, I'm a happy guy, right? Now, there are specific Lp(a) therapies that are coming, and there are monoclonal antibodies, there are small interfering RNAs, there are others. And the phase 2 data shows extreme efficacy, where we're talking like 80+% Lp(a) reduction. So there's the potential we'll have agents that are effective. Would that translate into reduced heart attacks and strokes? We don't know. There's the problem. It should. We believe there are small data sets that indicate it is very likely, but we are looking in the development pathway not only to find agents that work to lower the number, but also that are safe and that have outcome improvement when exercised in that way.
So I find it interesting, that study about monotherapy versus dual therapy. And so my question to you is, now with changing guidelines, possibly, I don't know how long it's been since for me at least, to look at the guidelines and say, hey, this is now what we're doing. From your perspective, what are cardiologists doing now as far as a treatment algorithm goes? Are we still just starting statins and then seeing what happens, or are some cardiologists jumping towards like dual therapy, or does it just really depend?
Well, the guidelines would ask you to do several things. Number one, you would start with a comprehensive evaluation and decide if this patient is a candidate for statin therapy. And that would include LDL cholesterol over 190, plaque in your vessels, diabetics 40 to 75 years of age, high lifetime or calculated risk. All of those are statin eligible patients. And the choice of agents is largely predicated on their demonstrated outcome improvement. So the reason statins are chosen as the usual starting first-line agent is because they have the largest body of data to demonstrate reduction in heart attack and strokes. Now, if you're on a statin and you need further LDL reduction, the next question is what agents have been proven on top of a statin to further reduce risk? And that would include ezetimibe, which is the generic for Zetia. That would include PCSK9 inhibitors, the monoclonal antibodies. That would include bempedoic acid, which was just shown at ACC to have a significant reduction in events. And so what the guidelines, which came out just a few months ago, say is start with a statin. If you need more than a 25% additional reduction to get to your threshold, go to PCSK9 monoclonal antibodies next. And if you still need further reduction, add either ezetimibe or bempedoic acid. If you need less than 25% on a statin to get to your threshold, the world is your oyster. You can use either ezetimibe or PCSK9 or bempedoic acid. So you've got 4 different agents with outcome-proven benefit that you can mix and match for a variety of reasons.
Awesome. Options are good. They're always good. Well, Dr. Cromwell, I want to thank you so much. I'm looking at my notes here, and we only got through about 50% of what I wanted to ask you, but we want to be respectful of your time. I know you're a wealth of knowledge, and I hope that you'll consider coming back on here because there's just so much more that we can touch on in this world and with all the experience that you have. We like to close with our little tradition by asking this important question because I think that's essentially the theme of the show. And a lot of things we touched on here and there in terms of our conversations about precision medicine and, patients advocating for themselves. But the question for you is, what does it mean to you, or how do you think we can add the health back to healthcare?
I think two things. Health is a function of maintaining the quality of life that people are really looking for. I see people all the time who come to me and they're a little ambivalent. Should I be on a drug? Should I not be on a drug? Should I start a statin? Should I not start a statin? And my question to them is, what does a great day look like 10 years from now? Now, don't answer it. Just think of it in your mind, a great day. And then answer the next question. Is that great day more likely or less likely if you have a heart attack or a stroke? Probably not more. So we need to get into the habit of making sure that the endpoint that we're looking for is health span, unrestricted ability to do activities that bring joy and meaning to our life, living in such a way that chronic disease is identified as early as possible and intervened on as definitively as possible with therapeutic lifestyle first, and then medications if necessary. The earlier we find people who are trending in the wrong direction, and we have, as you know, a huge problem with insulin resistance, obesity, metabolic syndrome. We find this in kids all the time. The time to intervene is then, to help them to change their trajectory to a better health span. So when they get into their 20s, now we're moving in a better direction, a more sustainable direction, versus I've seen people who have kind of a nihilistic approach. They see a large family with a large child and they just say, oh, well, that's just the way they are. I don't agree with that. I think we have to be proactive in creating opportunities to identify people early. And then we have to come up with some real world solutions. Unfortunately, in inner cities, there are food deserts. Where are people going to have reasonable non-McDonald meals, right? They have fixed income or a limited amount of money. They can't go out and spend it at Whole Foods on the best foods. They're going to have to find something else. What about physical activity? Now, how many people just aren't active at all? And how many times can we get people into a more active lifestyle? These are the things in my world that I see as low-hanging fruit. Find people early, find the first manifestations of them moving down this dysmetabolic pathway, intervene so that they don't have to stay there, and help them understand, down the road, the quality of your life is something that you have a lot of control over. And I would hate for you to be a victim of chronic disease in such a way that you are missing out on the things that you envision as being a great day 30 years, 40 years from now, or if you're, in your middle-aged years, 20 or 10 years from now. Just keep in front of you that, the quality of our life is really going to trump the quantity of life. I don't want to be that guy who's hanging on at the end of my life with the last 20 years of my life being awful because I was the victim of some, series of ill events from a chronic disease. So I think if we just keep the mindset of, early identification, early management, find solutions before things get to be embedded problems, that gets us a long way down the road.
We've got our work cut out for us.
Amazing.
Thank you, Dr. Cromwell.
Thank you. Before you take off, if you are interested in learning about your lipid markers, the numbers, and the metabolic health profile, I did link Precision Health Reports into the show notes, so be sure to click that. You'll get a full report. It's very easy. Altamont and I have done it. We've absolutely loved it, and we're excited to track our numbers as we progress on our own health journeys. If you did like this episode, if you think it will value somebody else, please send it to them. And if you've been enjoying this podcast, if you really enjoyed this episode, please do us a favor and leave a rating and review. We are trying to get to 50. So if you could help us out with that, we would truly appreciate it. As always, the medical disclaimer, everything in this podcast is for educational purposes only. It does not constitute the practice of medicine, and we are not providing medical advice. No physician-patient relationship is formed, and anything discussed in this podcast does not represent the views of our employers. We recommend that you seek the guidance of your personal physician regarding any specific health-related issues. And last but not least, thank you to our team, Ethan Ju and Haritha Yepuri. And with that, wish you the best week ever.